A warm doctors. I, Lajwanti Sharma, cordially welcome you for this webinar, Master Stroke on Approach to Autoimmune Encephalopathy. I would like to introduce Dr. Praveen Kumar and Dr. Swayam Prakash, who are the speakers for our webinar this evening. Dr. Swayam Prakash, a senior consultant, neurology and director, cognitive neurology, NGHC Siliguri. He has done his MBBS from JLN MCH Bhagalpur, MD in General Medicine from PMCH Patna, DM in Neurology, SMS Medical College Jaipur, SC in Royal Colleges of Physicians UK. He is the member of European Board of Neurology and has done his FRCP. He has 40 odd publications with 90 odd citations in index national and international journals. The area of special interest are cognitive and autoimmune neurology. He is the member of several international and national professionals bodies, the recipients of several academic, professional, and social accolades and honors. Our next speaker for the evening is Dr. Praveen Kumar Yadav, a senior consultant neurologist in Arugam, Durgapur, and assistant professor at SRIMS Durgapur. He has done his MBBS, MD, and DM neurology from Kerala. He has also done his MRCP UK and London, FRCP from Edinburgh and London, FEBN, SE, RCP and London. He is an examiner to Royal College of Physicians UK. He completed certifications in neuroimmunology, pediatric neurology, and epilepsy. He has many national and international publications. He is the editor board and reviewer panel of index journals. Special area of interest, neuroimmunology and sleep medicine. Now, I would request Dr. Praveen Kumar Yadav to take us through the session. Sir, I would request you kindly share your screen. Over to you, sir. Thank you.
Thank you for the kind introduction. Am I audible and visible? Okay, I'm just sharing my screen. Is it visible? Okay, is the slide seen? Hello? Okay. So, good evening all and welcome to this webinar on autoimmune encephalitis. So basically what we'll do is I will be briefing about the autoimmune encephalitis, the general approach to autoimmune encephalitis, and I'll be focusing on the most common cause of autoimmune encephalitis, that is NMDR receptor encephalitis. And Dr. Swayam Prakash will be showing us a lot of exciting videos about various types of encephalitis and also the approach to other autoimmune encephalitis. So I'll start with a history. So this is a case which I had seen around 4 or 5 years back, and this is the history of a 20-year-old female. She was a normal, absolutely normal before this illness. She was a BCom student. She presented with 10 days history of altered behavior, irrelevant talk, and aggressive behavior, and was evaluated by this psychiatrist outside and was treated for 10 days. And she had a history of mild fever on and off for last 2 weeks. She presented to the neuromedicine, she presented to the emergency with 2 episodes of focal seizures which turned into generalized seizures, and then she was admitted in the ICU. When I examined the patient was conscious, disoriented and agitated, and there was terminal neck stiffness. However, there were no focal neurological deficits. There were no rashes. There were no lymphadenopathy, or she was mildly febrile. So, are my slides visible? Okay. So, what were the possibilities? A young female presenting with fever, altered mentation, psychiatric symptoms, and seizures. So, the first possibility which we consider is viral encephalitis, as we have been taught right from our MD days. Fever with altered mentation and seizure is encephalitis, and the most common encephalitis is viral encephalitis. So, in the same way, I thought of viral encephalitis, started her on acyclovir immediately, and I gave an antibacterial cover also because I was not sure till the CSF arrived. The MRI was done with contrast, which was initially normal. So this was the initial contrast MRI, which was done on the second day of admission in the morning next day, and you can see it is normal. There are no flare intensities, no abnormalities, no cortical swelling. And because she was having altered mentation, the scan was repeated after 4 to 5 days. And this was the repeat scan. And on discussion with the radiologist, there was some doubt whether there are some cortical hyperintensities, but it was not very obvious. The CSF was done. The CSF showed 4 cells, predominantly lymphocytes. The protein was normal. The sugars were also normal. It was 70. So a normal CSF was the report. The EEG was done, which showed generalized slowing, which was done in the next day, and then she had a seizure 1 day prior. So it was probably postictal slowing was there. HSV PCR was done, which came back by the 7th day, which was negative. The patient was continued on antiviral and antibacterial medications. On the 5th day, I could note that the patient became mute. So she was agitated and psychotic initially, and she became mute with perioral dyskinesias and posturing of the limbs. So at that time, I realized that this was something else. It was not a viral encephalitis. So this is the summary. A young female with encephalitis-like picture. MRI mildly abnormal, doubtful. CSF was normal. HSV PCR was negative. And with psychosis and movement disorder. So this was the characteristic picture. Now, if we have this scenario, this is straight away a diagnosis of autoimmune encephalitis. But around 4 to 5 years back, this was not very common. Autoimmune encephalitis was just emerging at the time. Even the antibody tests were not available commercially widely. So I thought of autoimmune encephalitis. I think this can be muted.
Presentation. I can hear.
So CSF and the serum NMDR antibodies were sent to Neuroimmunology lab at Amrita Institute, Kochi, because it was not available at the routine labs, which are now it is widely available. So at that time it was not available, so I had to send the CSF.
Sorry, Dr. Praveen.
To Dr. Sudhir.
I can't see your presentation, Praveen. I think it's not visible. Can some IT people intervene and correct it?
So the slides are not visible?
No, not visible.
No, I can not using it. It's still on the first slide.
Okay, 1 second. I will. So are these slides visible now?
Not yet. Not yet.
Hello, is it visible? Is it visible, Dr. Shyam?
No, it's not visible to me. I don't know about others, but it's not visible. I can hear you well, but I can't see you. Yeah.
Okay, what about now?
Not yet, Praveen.
Is it visible? Yeah. Yeah, I'm moving it, right? Hello?
Yeah, it's not coming yet.
Shall I do it again?
Yeah,
Hello?
better. Yeah, better. I think just try to do it again.
I'm sharing it again. Hello.
Yeah. Do that.
Is it visible?
Yes. Yes, visible.
Okay. Yeah, I think Dr. Swayam, can you see it?
Yeah, I can see it. I can see the slides now, but you are not visible. I can see the slides, but the MRI slides are visible.
Okay. Is the slides visible now? Okay, so we had a young female presenting with abnormal fever, altered sensorium, psychiatric illness, and then movement disorder in the 4th day. And this was the CSF, which was sent to Amrita Institute, Cochin. And then we had found that the CSF NMDR antibody was very highly positive, as well as the blood antibody levels were highly positive. So in view of the blood and CSF positivity and the LGI1, Casper2, as well as the antithyroid antibodies, TPO, everything was negative. There was no history suggestive of any systemic autoimmunity like lupus or all other things. The ANA, however, was sent, which was negative. The EEG, which was done later on, showed extreme delta brushes, which I'll show now. The ultrasound abdomen and the pelvis, including a transvaginal ultrasound, was done. I consulted the gynecologist and they had a special, they checked the ovaries and there were no teratomas or no other significant lesion in the abdomen. So the final diagnosis of NMDR encephalitis was made. So this is the EEG, which shows the delta brushes. So you can see that there is delta slowing, and on top of that there is a fast beta activity. So this is called as extreme delta brushes, and this is quite specific, though not sensitive for auto NMDR encephalitis. It is seen in 30% of the cases, but if it is seen, that signifies a bad prognosis, and it is the normal pattern in neonatal EEGs, and then we can see this pattern in NMDR encephalitis. Now, seeing this picture, I started the patient on intravenous immunoglobulin for 5 days along with steroids, and there was not much improvement. The patient had worsening of dystonia, developed florid movement disorder, the mentation worsened. She developed severe opistotonic spasms. Unfortunately, the video I'm not able to play because the video has got corrupted. It's not playing properly, but she had severe opistotonic spasms. In between, she would go for these extensor spasms, and there were oculogyric crises as well, and the recurrent seizures which were not responding to the medication. She was on 4 anti-epileptic agents. She was on lorazepam TID 2 mg, quetiapine quite high dose 300 mg, and anticholinergics. Yet there was not much control over the symptoms. I waited for almost 10 to 14 days, and after that I thought the IVIG and the steroids was not doing its job. So I went on to the second line of treatment, that is rituximab. 500 mg weekly was given for 4 weeks. And after that, after the second week, after 10 days onwards, I could see that the patient started improving. The altered mentation started to improve. The spasms disappeared. The seizures started to get control. She was there in the hospital for 3 months. And after almost 1 to 1.5 months, I could shift her out of the ICU. And then she was there in the ward for 6 weeks. And then discharged after 3 months of the hospital stay. The steroids were given and then it was tapered and stopped in 3 months. Anti-epileptic drugs, benzodiazepines, trihexyphenidyl, and antipsychotics were gradually tapered over 6 to 9 months. And she was continued on azathioprine for almost 1.5 years, and then which was again tapered and stopped. She has been under my follow-up for the last 4 years. She's back to her studies, completed BCom. She's married recently. She's absolutely normal. She had some mild memory and behavioral issues for the 6 months, and then which has improved. Ultrasound abdomen has been done in association with the gynecologist, and every 6 months this has been repeated for the last 4 years, and there were no teratomas which had occurred. So this was the history of my patient who finally became normal after treatment. So that is the introduction of autoimmune encephalitis or the NMDR encephalitis, which is the most common type of autoimmune encephalitis. And here is one book, that is Brain on Fire by Susan Ann Callahan. She is a patient who developed this autoimmune encephalitis, and this is what she has to say. My tongue twisted when I spoke, I drooled and when I was tired, let my tongue hang out of the side of my mouth like an overheated dog. So this shows the oral dystonias, the oral involuntary movement, the autonomic dysfunction, the overheating and the drooling, and the psychotic symptoms, that is the fear and the anger. So that shows the extreme psychotic symptoms, movement disorder, which this NMDR encephalitis causes. It has been depicted in previous movies as well, like in The Exorcism of Emily Rose. You can see that a lady develops this sort of severe psychotic behavior, movement disorders, and finally succumbs to the illness. So in this movie also, it's probably autoimmune encephalitis, and this is in the late 1970s, 80s. So at that time, we didn't have this concept of autoimmune encephalitis. So probably it is a very old disorder, and with the advent of neuroimmunology, we are able to diagnose this condition. So that brings us to the topic of autoimmune encephalitis. So basically, encephalitis is inflammation of the brain parenchyma, which is characterized by altered sensorium, seizures, and low GCS, and a abnormal CSF, MRI, or EEG finding. So that is the basic definition of encephalitis. Now, encephalitis, as we all know, most common is infectious encephalitis, in which viral encephalitis like herpes, Japanese encephalitis, West Nile encephalitis, and a lot of endemic encephalitis are there, which can cause the most common cause of encephalitis. After that, we are having the idiopathic cases. Now, if you look at the non-infectious cases, major chunk of this is idiopathic. That means for which we do not have the antibodies right now, but these are all antibodies, some or the other antibody mediated autoimmune encephalitis. Then you are having the autoimmune synaptic encephalitis, which we'll be focusing more today, the paraneoplastic, and the ADEM, the acute disseminated encephalomyelitis. So these are the common causes of encephalitis, that is viral, autoimmune, and ADEM. And the autoimmune can be autoimmune synaptic or paraneoplastic and unknown autoimmune encephalitis, which are there. So why should we know about autoimmune encephalitis? This is one project, the California Encephalitis Project, which found out that it was an epidemiological study, and it showed that almost 62% of encephalitis admitted, despite doing extensive viral investigations, are unknown. So the causes of such encephalitis are unknown, and most probably most of them are some sort of autoimmune encephalitis. So it is a very common disorder, and we are not able to diagnose it because of the lack of neuroimmunological services. And now with the emergence of neuroimmunology and the investigations, we are able to diagnose this condition more and more. So here again, you can see that in the California, this is the British California Encephalitis project, which shows that in young patients less than 30 years, the NMDR encephalitis is almost as common as the viral encephalitis, like Epstein-Barr virus and the other viral encephalitis. So it's a common disorder. And this again, it's a US epidemiological study which shows that herpes, ADEM, and antibody-mediated encephalitis are the three common encephalitis which affects the patient. So it is a relatively common disorder, and NMDR encephalitis may be as common as a single viral encephalitis. But if you take all the viruses together, the viral encephalitis are more common than autoimmune encephalitis. But taking a single etiological agent like herpes, probably NMDR encephalitis will be more common than herpetic encephalitis. So it is of quite significance that we understand and try to know about this condition. So common autoimmune encephalitis, you can basically divide as paraneoplastic encephalitis, which I think Dr. Swayam Prakash will be discussing more about that. Then steroid responsive encephalopathy, street or Hashimoto's encephalitis, which we'll not be discussing in this presentation. Then inflammatory conditions, all the vasculopathies like SLE with neuropsychiatric lupus, Behçet's disorder, Sjogren's syndrome, the APLS syndromes, the MOG antibody related disease, or the GFAP antibody mediated disease. All these are inflammatory disorders. So this form a major chunk of the disease, the Hashimoto's, paraneoplastic, and these are the disorders which we'll be focusing today on, that is the surface antibody mediated disorders, NMDR, AMPA, GABA, LGI1, Caspr2, DPPX, IGLON5, and so on. So this spectrum is, there's an explosion of new antibodies which are coming in. So if you look at this, this is the spectrum of autoimmune encephalitis. and almost 73% are taken up by the single neuronal surface antibodies like NMDR and all the LGI1 and Casper, etc. And 33% is by intracellular antibodies like all the paraneoplastic, anti-HU, anti-YO, TR, and so on. And 12% is by systemic disorders like neurolupus, Behçet's, sarcoids, Sjogren's, and all those things. And one chunk, 3 to 4%, is by the aquaporin antibodies. So there is an overlap between autoimmune encephalitis and NMO spectrum and the MOG spectrum disorders. So that is again a common point. 4% are unknown autoimmune disorders for which antibody are yet to be discovered, and 5% of them may have a mixed pattern. There may be a mixture of antibodies which you may be able to illustrate. So this is the spectrum of autoimmune encephalitis. Why should we know whether it's an intracellular antigen or a neuronal surface antigen? It is important. Like the intracellular are usually paraneoplastic, and the neuronal are paraneoplastic in 60 to 70%, and we'll be focusing on this group. So why should we know about this group? So the importance is the treatment and the outcome. The intracellular are found to be directly pathogenic. They are T-cell mediated, T-cell cytotoxic T-cell mediated. They are almost always paraneoplastic, and they have poor response to immunotherapy. And the treatment is mainly treatment of the malignancy. So that has to be done. The chances of recurrence are less in intracellular the antibody mediated disorders. While in the case of extracellular, that is the surface antigen, the response to immunotherapy is very good. They have more chances of recurrence, and the tumor association is less. So the prognosis and the management depends on the type of the antibodies which you detect. So that is why we should know. And it is seen that extracellular epitopes of the cell surface will cause reversible neuronal dysfunction. So it has a better outcome, while the intracellular proteins will usually have cytotoxic T-cell mechanisms which will cause neuronal loss and permanent damage. So that gives rise to the poor response to the treatment. Now this is again one cartoon which shows that. So this is the surface antigen, NMDR, Casper, IgL15, glycine receptor, LGI1, AMPA, GABA-B. All these are surface, and the intracellular are all the onconeural antigens. Even the GAD is intracellular. So the more the intracellular, the higher chances of malignancy, and the pathogenesis is due to T cells, and immunotherapies have limited effectiveness. And more the surface antigen, the more treatment response, and they respond to decrease in the antibody production or elimination of the antibodies like plasmapheresis. And the first line of treatment is steroids, IVIG or Plex, and the second line, which we'll be discussing, rituximab, cyclophosphamide, and so on. So that is the importance of knowing what type of antigen actually we are dealing with. So what is the relationship of malignancy? If you look at the relationship, it is seen that the paraneoplastic is due to the intracellular antigens, as I already mentioned. So it is usually paraneoplastic. So there is complete association of malignancy. Now, intracellular are rarely paraneoplastic, especially LGI1 and GAD. So it is not usually paraneoplastic. NMDR and Casper are somewhere in between. And if you look at AMPA receptor and GABA receptor, they are usually, and mGlur5, these are usually commonly paraneoplastic. So when we move from here to here, the malignancy increases, and the least association with malignancy is with LGI1 and GAD, and the maximum is with the intracellular antigens. So this is one very important image from Dalmau's article. And here again it shows that, so this is cell surface antigens. You can see the antibody is attacking the cell surface, and here it is the intracellular antigen. So the antibodies cannot get inside the cell. So what they do is they use the cytotoxic T cells to attack the cells, and this causes neuronal loss. So this is the staining of the mouse brain, and which shows that in the surface antigens, you can see there is diffuse staining in the surface, while if it is intracellular, you will get staining inside. And this is a single neuron, which shows that there is staining in the surface of the dendrites and the neuron, while in the intracellular there is no staining inside. So that shows the presence of the antigen. So this is a special antibody staining, CD138, and you can see the antibodies are being stained here. And this is a H&E staining, and this shows that you can see there is phagocytosis of the neurons by the T cells. So in intracellular antigens, there is direct necrosis and phagocytosis of the neurons that gives rise to less immunoresponsiveness and more severe manifestations and less responsive to treatment. So that brings us to the definition. What is autoimmune encephalitis? I think I have already explained. It's an inflammatory brain disorder with prominent neuropsychiatric symptoms. So how do we differentiate it from viral encephalitis? The differentiation may be very difficult, and then you have to have a high index of suspicion. The first thing is a subacute onset. So if there is a subacute onset of the illness, prominent neuropsychiatric symptoms, movement disorder, prominent limbic features like memory loss, recent memory loss, old memories are preserved, and the fever is there but not very high grade as in a viral encephalitis, and the course is not very rapid. So in such patients, you should suspect autoimmune encephalitis. The prevalence is 5 to 8 cases per 1 lakh, and you can see that it is the third most common cause after viral ADAM, and then the third most common is autoimmune encephalitis. And NMDR is the most common autoimmune encephalitis, followed by LGI1, which is the second most common cause of autoimmune encephalitis. Now, this is the entire spectrum of autoimmune encephalitis, and you can see there are a lot of manifestations. I will be dealing on the NMDR encephalitis. I will be dealing in detail. Rest of this will be dealt by Dr. Swayam Prakash. And LGI1, as we all know, we have the classical facio-brachial dystonic seizures, brief complex partial sort of seizures which occur, whether it's a seizure or movement disorder, still it is confusing thing. So that is the hallmark. Casper 2, the hallmark is neuromyotonia, and there is peripheral involvement, and there is also dysautonomia when it is called as Morvan syndrome or Isaacs neuromyotonia. And the AMPA receptor again causes limbic encephalitis. GABA A receptor causes rapidly progressive encephalitis. And one important thing is that malignancy chances are more in AMPA and GABA will have classic MRI appearance. So you will get flare intensities involving the cortical and the subcortical areas, which may mimic a ADAM, like a MOG disorder. So that is the closest DD of GABA receptor encephalitis. GABA B is again seizure and limbic encephalitis. Then you are having Eglon 5, it is a new entity, and then this disorder presents to the sleep medicine specialist. So they will have a lot of sleep related parasomnias. They will have bulbar involvement, and one more very important presentation is a PSP like presentation. So they may mimic a progressive supranuclear gaze palsy disorder. So Eglon 5 is one disorder which can have all this presentation. DPPX presents with severe diarrhea and significant weight loss and all those symptoms, and there will be hyperplexia and CNS hyperexcitability. All those things are there. Neuraxin 3 alpha will be like a NMDR encephalitis, and the serology and the antibody will be negative. So it is NMDR encephalitis looking like NMDR, but the antibodies are negative. Dopamine receptor will have predominant basal ganglia symptoms. So all the spectrum, there are some classical findings which are there and which are special to a certain group of disorder. Now, if you look at the spectrum, you can see that CSF, regarding the age, NMDR is usually in the younger age group. It can start from 3 years up to, cases have been described up to 75 years. LGE1 and Casper is higher in the middle age in the elderly population. Similarly, AMPA and the, hello? Slides are not visible? Yeah.
The slides are visible, but it has stuck up. It's not moving.
So the issue is that most of the slides I have made it like I'm not presenting it in this presentation. So that is the problem. Okay, because a few of the slides have been hidden, There are a lot of slides, I'm not presenting all of them. So that is the issue.
Yeah, okay, no, go ahead.
Okay, anyways, we'll go on with the presentation. Now, if you look at the CSF is usually abnormal in almost 70 to 90% of the encephalitis, autoimmune encephalitis. Like in NMDR, it's almost 80 to 90%. AMPA, it's around 90%. But in case of Casper and LGI1, the CSF may be normal. So the CSF may almost be normal in Casper and LGI1. So you should have a higher level of suspicion, and you have to do the serum levels also of the antibodies in the case of LGI1, because sometimes it may be detected only in the serum and the CSF may be negative in cases of LGI1 encephalitis. These are the tumor associations. I'll not go into the detail. The classical tumor of NMDR encephalitis is a ovarian teratoma. However, other tumors like lymphomas and small cell carcinomas and mediastinal lymphomas all have been associated. And thymoma is a common tumor which is commonly seen. GABA is associated with small cell carcinoma of the lung. And IGLON and DPPX, so they have very less malignancy association. So that is one important point. The chances of malignancy are less. Now this I have already mentioned. Usually the course is subacute, but Casper2, DPPX and LGI1 may have a very long course. So it may run in months up to a year also. So there it may mimic a neurodegenerative disorder also. So you have to be careful when you are dealing with such cases. The common phenotype is there, but two specific phenotypes which we can see is NMDR encephalitis, which presents with the neuropsychiatric symptom, movement disorder, dysautonomia, and the sleep disturbances and all those things, and the limbic encephalitis, which presents with the classical memory loss, recent memory loss and seizures and all those things. So this two pattern you can find out whenever you are seeing the patients. So limbic encephalitis, I need not tell the features, symptoms I have already mentioned, and the MRI will show flare abnormalities involving the medial temporal lobes which are seen. So in this case, you have to differentiate it from herpes encephalitis and also postictal edema and glioma. So this thing has to be kept in the differential diagnosis, and then you have to discuss with the radiologist and come to a conclusion. And usually there will be no gadolinium enhancement, unlike herpetic encephalitis, which shows hemorrhage, which shows gadolinium enhancement, which shows diffusion restriction. Here usually you will not have these findings. And LGI1 again has severe hyponatremia which can be there. Tumor is less, I have already told that, and refractory status in GABA A. So all this I have mentioned in the chart itself. So I will skip this. Now the classical findings, usually autoimmune encephalitis does not have a classical MRI finding. In almost 50 to 60% of the cases, the MRI may be normal also. But in two conditions, MRI may show findings. One is limbic encephalitis, which I have already mentioned. Second is GABA A receptor encephalitis. So you'll have subcortical flare hyperintensities, which may be quite classical of GABA A receptor encephalitis, and MOG or the ADAM are the closest DDs. So again, I'll show a few findings. So this is one patient presenting with NMDR encephalitis. You can see cortical hyperintensities. This is a D2 receptor encephalitis. You can see bilateral symmetrical involvement of the caudate and the putamen. This is a limbic encephalitis, asymmetric involvement left more than right. And this is the classical picture of GABA A receptor encephalitis, and you can see it is quite similar to that of a MOG encephalitis, which has been kept here. So almost similar picture. And this is a patient of AMPA A receptor encephalitis. We are having cortical hyperintensity. So the variety of findings may be different. So you may have a lot of variety of findings, and you should have a high index of suspicion. Even if the MRI is normal, or if shows a vague pattern or abnormal pattern, you should have this diagnosis in mind if the clinical picture fits into. Coming to CSF in autoimmune encephalitis, moderate CSF pleocytosis is seen. However, absence of pleocytosis does not rule out the diagnosis. And LGI1 and DPPX, normal MRI may be there, and CSF may also be normal in these patients. And the neuronal autoantibodies are detected in CSF, even if routine CSF is normal. So it means that you cannot do the CSF, you just do the CSF, TCDC, protein, sugar, and then say if it is normal, I will not do the autoimmune panel. Because sometimes the basic CSF investigation may be normal, and when you do the immune panel, you can see that the antibodies are positive. So it has to be done completely if you are having a high clinical suspicion. And anti-IgG1 may have serum or CSF, so there may be a discordance. So you have to do both serum and CSF if you are suspecting LGI1. And one more thing is, like in NMDR, the CSF is positive. Only for 14% they may have only CSF and no serum. So sometimes we have seen that some people send only serum NMDR antibody. So you may miss because CSF may only have the antibodies in 14%. So both has to be done whenever it is being done. Sometimes there may be two antibodies, like AMPA may be there, GABA may be there. So which is causing the symptom, or NMDR and GABA? So then you go with the CSF. Whatever antibody is found in the CSF is probably giving rise to the disease. And the CSF antibodies may have some correlation with the disease also in NMDR encephalitis. However, this is not directly proportional. There may be variation. Sometimes the CSF may be showing positivity, still the patient is improving. So you will go with the clinical patterns, but it may have correlation with NMDR encephalitis. And if the serum may show false reports also, there may be false positive reports in the serum. So that it is better advisable to do both CSF and serum antibodies. Now the prognosis usually depends on the type of the antibodies and the tumor which is detected. However, in NMDR encephalitis, the prognosis is good. Almost 53% improve by 4 weeks. 81% has substantial recovery by 2 years. And LGI1 also, it has a rapid response and by 70% respond by 2 years. So overall, the prognosis is not very bad. And if you start immunotherapy early, the prognosis is good. And the frequency of relapses in most of this encephalitis ranges from 12 to 35%, while it in NMDR it's around 15 to 24%. So we had few questions also. Is there any clinical criteria for diagnosing autoimmune encephalitis? Yes, there is a clinical criteria also. So this is the clinical criteria, out of which all three has to be fulfilled. One is subacute onset, that is less than 3 months of memory deficit, altered mentation, and psychiatric symptoms, and at least one of the following, that is new focal CNS findings. So there should be some focal neurological deficits. Seizures should be there, and there should be no past history of seizure disorder. CSF pleocytosis more than 5 cells, and MRI should be suggestive of some encephalitis-like picture. So any one of this and the clinical profile. So if you have this, and if you are excluded other causes, the other causes I'll come in the differential diagnosis, which includes vasculitis, demyelinating disorders, all sort of disorders you have to rule out. And if you have ruled out that, and if it fits into the clinical criteria, then you can make a diagnosis of possible autoimmune encephalitis. Now, definite autoimmune limbic encephalitis, again, all 4 has to be satisfied. First is the same memory loss, psychiatric symptoms, and then bilateral MRI abnormalities should be there, and at least CSF or EEG should be abnormal, any one of this. And if the MRI is normal, a FDG PET scan can be used. So that is one important investigation which can be used, but the availability is an issue. If the MRI is normal, sometimes FDG PET will show metabolic abnormalities in those part of the brain. So it may be more sensitive than MRI in finding out the diagnosis. So here you can make a definite diagnosis of autoimmune limbic encephalitis. So now coming to the differentials. So differentials are, most important is infections. So viral infections, all sort of viral encephalitis, bacterial encephalitis, especially listeria, mycoplasma, rickettsia and all those things, syphilis, Lyme's, fungal infections. Sometimes Whipple's disease and Creutzfeldt-Jakob can be a close differential diagnosis. Toxic metabolic conditions, drugs can cause Wernicke's encephalopathy. Neuroleptic malignant syndrome is a very, which may mimic NMDR encephalitis. So that is one DD. And vasculitis, neoplastic disorders like leptomeningeal metastasis, diffuse glioma, slowly infiltrating glioma around the brain, the limbic area or the basal ganglia can present with similar things. And this is one important disease which you have to rule out. Multiple sclerosis is less likely, NMO and Mach spectrum disorder and ADAM. So this has to be ruled out. So these are the differential diagnosis which has to be excluded. Okay, so these slides I'm not going to present. So next we'll go to NMDR encephalitis. So that is the problem. Lot of slides I'm not going to present in this. Okay, now coming to the pathophysiology, what happens in NMDR encephalitis? The antibodies, the IgG antibodies bind to the NR1 subunit of the NMDR in the postsynaptic membrane of the CSF. This causes cross-linking and internalization of the NMDRs, reduces the number of the NMDRs and the clusters on the surface of neuron, causing dysfunction and disease. Now, NMDR receptors are very important in synaptic transmission and signal transmission between the neurons. And as this is lost, it causes a host of manifestations which manifest as the manifestation seen in NMDR encephalitis. The inhibition of the GABAergic neurons are lost, and that causes excitatory influence. And all the circuits get excited. You are getting the frontostriatal syndrome. You are getting the brainstem central pattern generators, and then you will get the orofacial dyskinesias, involuntary movement. The dopaminergic, cholinergic, and the adrenergic neuronal hypofunction occurs, which causes dysautonomia, and the pontomedullary junction is affected, which causes the hypoventilation. So all this gives rise to the gamut of the manifestations which we see in NMDR encephalitis. Now, it is a female predominant disease. Mean age is 21 years. Now, there is a difference in manifestation in children and adult. So, children present with seizures, abnormal movement, insomnia, and irritability, while psychosis and behavioral problem are more common in adults. Similarly, adults will have severe manifestations like hypoventilation and dysautonomia, which is more common in adults, and less frequent movement disorder and speech abnormalities. Now, within the first 12 years, 12% relapses, and it is seen that the relapses are less severe than the main disorder. Now, this is one important slide and probably one of the most important slide. There are 5 stages of NMDR encephalitis. First is like a viral encephalitis with fever. However, the fever may not be very high like in viral encephalitis, and the fever will be mild fever. They may be having headache, some flu-like symptoms, body pain, diarrhea, and all those things may be there. And the first initial symptom in which the doctors are met is a psychiatric symptom. So they present with a variety of psychiatric symptoms which I will be discussing, and they go to the psychiatrist first, and from there the reference to the neurologist comes at this point when they develop the seizures. So after that, the psychiatric symptom, they develop the seizures and they become mute. They may developing catatonia, seizures, and all those manifestations. And then after that comes the hyperkinetic stage, in which you are having the orofacial dyskinesias, bruxisms, and all those things. All the oculogaric crisis, opistotonic spasms may be there, and the fatal problems related to this are the refractory seizures, that is the status epilepticus may occur. They may develop severe dysautonomia, which may even give rise to cardiac arrest, heart blocks, and hypoventilation. So these are the fatal complications which may occur, and then finally they go into the prolonged recovery stage. All the stages may not be seen depending on the treatment where you are giving. Suppose you are starting immunotherapy, then the further stages may be absent. These are the stages of the illness, again taken by latest presented article by Dr. Dalmau, and the viral prodrome is for 1 week, and then you are having 1 to 2 weeks of psychiatric symptoms, and you will have delusions, hallucinations, mania, etc. So both positive and negative psychiatric symptoms will be there. It may require inpatient admission, so they will be admitted in the inpatient ward, and then they may be developing catatonia and all those things. They may be having neuroleptic hypersensitivity. So once the antipsychotics are started, they may go into a NMS-like picture. And later on, they will develop the neurological manifestations, which include movement disorders, dysautonomia, hypoventilation, and refractory seizures. And finally, the recovery phase is a prolonged phase with a lot of executive dysfunction, memory issues, and all those things. So this again shows the phases. So you have to remember that initial is psychiatric, and second is there may be sleep disorders also. So the initial stage there is insomnia, and the later stages you will get hypersomnia. So when the patient goes into the florid neurological manifestation, the patient develops hypersomnia, and initially there will be severe insomnia. They will not be sleeping. They will be psychotic, and there may be developing language dysfunction. So this is very important. They may develop aphasia, some echolalia, echopraxia, mutisms may be there, and later on seizures, movement disorders, and dysautonomia. And the recovery also occurs in the reverse way. So these things will recover first, and later on you will get improvement in the memory and all those things, which may last for some time. Minor psychiatric symptoms may be there for some time. So these are the psychiatric symptoms. It's a mixed bag. So based on the psychiatrist, they say that you will get a mixture of psychiatric disorders. So it will be a mixed bag of psychiatric disorders, which will not be fitting into any of the criteria of a certain psychiatric disorder. So they'll be having features of everything: psychosis, some depression, some mania, everything will be there. And 40% will require psychiatric symptom. One important thing is 53% of this patient will have neurological abnormalities when they are evaluated by the psychiatrist. So if there is a high index of suspicion, these patients may be detected early, and then we can start immunotherapy very soon. And 47% may develop hyperthermia, muscle rigidity, coma, and rhabdomyolysis due to neuroleptic intolerance. And complex psychiatric symptoms are there. A very important DD is neuroleptic malignant syndrome. You never, because both the features are same. NMS will have hyperrigidity, dysautonomia, fever, and all those things. Similar things occur with NMDR encephalitis. So whether the disease is causing the thing or whether the antipsychotics are causing this may be sometimes confusing. So this is one mnemonic which has been given by Dr. Dalmau for the psychiatrist. Search for NMDR. So whenever they see these patients, you should remember this mnemonic, that is search for NMDR. Whenever psychiatric patients are being seen, that is, you look for sleep disorder, you look for the psychiatric symptoms, agitation, excitement, you look for the rapid onset of symptoms. Usually in schizophrenia, the symptoms will be gradual in onset, and then you will have negative symptoms first and then positive symptoms, while here you will have a rapid onset of symptoms and there will be a mixture of positive and negative symptoms. And then the history of psychiatric illness, usually there will be no history of psychiatric illness. Fluctuating catatonia is a very important manifestation. Negative symptoms, memory deficits, and all those things. Antipsychotic intolerance. So this should give them a clue that they are dealing with not a primary psychiatric disorder and it is something else. And that can give early referral, and we can start the immunotherapy and diagnose these patients early. Sometimes ECT may also be required, though it is not very helpful. I'll not go into the detail. So ECT has been tried in few patients with severe psychotic, severe catatonia, and there has been response, mixture of response. In few studies they say it is useful, and few they have not found it to be very useful. Movement disorder, I think Dr. Swayam Prakash has a lot of videos regarding that. Oral, facial, lingual dyskinesias are the most common type. Self-injuries may be there, and then you have to give immune therapy, tetrabenazine and botulinum may be effective. Seizures. So seizure is a very important manifestation. All sort of seizures can occur. Complex seizures, generalized tonic-clonic seizures, status epilepticus, refractory status epilepticus. So it's a very important cause of status and refractory status epilepticus in the ICU. Now, one important thing is that it has a very good prognosis. So once you start immunotherapy, usually these patients will not become epileptic. So the epilepsy will subside and long-term anti-epileptic medications are not needed. And by 2.5 years, most of the patients become normal and seizure-free. So that is good news. And intensive care, again, intensivist has to be aware with this condition. It can be really difficult to manage these patients, and they'll have dysautonomia and all those things. True seizure from dyskinesia may be difficult. Sometimes we go to the ICU and then they are giving lorazepam and all those things because there is perioral dyskinesia and they think it is some status epilepticus or some seizures which are going on. So quite difficulty will be there. Fever will be there because of the dysautonomia. So whether it's a nosocomial infection or due to hypothermia is again one important thing. Dysautonomic cardiac arrest may be there. So pacemakers, temporary pacemakers may be required. The dyskinesias and ophistotonic posturing may have difficulty in ventilation and keeping the airway devices. Lot of anti-epileptic medications, lot of other medications are there. So side effects, nosocomial infection, complications. So it is it's basically management of NMDR encephalitis becomes a team effort. So you need the psychiatrist, you need the intensivist, you need the neurologist. Everyone should be there, and then only you can manage this patient, because severe cases can be really difficult to manage, and there may be a lot of complications which has to be handled by the intensivist team. So this is the basic difference between adult and childhood NMDR encephalitis. So seizure more common in children, and hypoventilation and autonomic symptoms and psychosis more common in adult, and relapses are more common in adult compared to children, and teratomas are more common in adult compared to children. So less than 18 years, the teratoma risk becomes less. So this is the diagnostic criteria for NMDR encephalitis, and there are 6 symptoms they have mentioned. So abnormal behavior, speech abnormality, seizures, movement disorder, decreased consciousness, and autonomic dysfunction. So 4 should be there out of this, and there should be at least abnormal EEG or CSF. So all this, you can say it is possible NMDR encephalitis. So you can suspect NMDR encephalitis even without the antibody, if there is the characteristic feature, the phases and all those things are there, and definite when you have the antibody positive. So then you can say it's a definite NMDR encephalitis. So there is overlap with NMO and MOG spectrum. 5% has the overlap, and this overlap with aquaporin or MOG is quite seen, while with GFAP, that is the glial fibrillary acidic protein antibody disease, the overlap may be not very clear. However, the differentiating features are optic neuritis, myelitis, and area prostinema syndrome and all those things are more common with the NMO and the Mach spectrum disorders. However, there may be a spectrum and both may be present in a patient. So it has to be evaluated properly. So what are the paraclinical features? Now, what is the importance of EEG in this patient? So EEG, it is seen that EEG may be more useful than MRI in NMDR encephalitis, and EEG is usually abnormal in 70 to 80%. So there may be some abnormality, generalized slowing, focal slowing, all those things may be there. However, if there is extreme delta brush, so that is quite significant, and that may guide us towards the diagnosis, and it also shows a poor prognosis. It is more useful than MRI. MRI 50% may be normal. Some patients may show abnormalities in the temporal lobe, hippocampal areas, and FDG PET may be a better investigation if it is available. It helps in the diagnosis and also helps in the recovery assessment. So it can also help us in prognosticating the disease. CSF 80% it is initially abnormal, and later on it becomes more and more abnormal as the disease progresses. In the older adults, the CSF and the MRI may be normal. CSF oligoconal bands may also be positive in this autoimmune encephalitic disorders. So what are the tumor association? 60% has ovarian teratoma. Less than 18 year, the association is 25 to 31%. More than 18 year, it is 55 to 60%. Other tumors have also been seen, like mediastinal teratoma, small cell carcinoma, Hodgkin's lymphoma. No tumor in 40%. And you should follow up these tumors, patients for 4 years with 6 monthly transvaginal ultrasound scan for teratoma, because there are many cases in which teratoma can occur later on also. So there has to be strict follow-up for these patients. Now there is one important point: without a tumor, NMDR encephalitis has a bad prognosis compared to that of NMDR encephalitis with a tumor. 80% overall has good prognosis, 20% has focal deficits and death. And the time to recovery median is almost 2.5 months, and 15 to 24% may relapse by 18 months. And persistently high level of antibody usually signify bad prognosis, and aggressive treatment is required. So how do you prognosticate this patient? So there is one score which is called as the NEOS score for poor prognostic factors, which tells us about the poor functional outcome at 1 year. And so these are the various things. If the patient is admitted in the ICU, so that's a bad prognostic, you score 1. There's no clinical improvement after 4 weeks of treatment, you score 1. No treatment within 4 weeks of symptom onset, that is delayed treatment, score 1. Abnormal MRI and CSF more than 20 cells. So all these are bad prognostic factors, and there is 3% poor functional outcome by if there is 0 to 1 point, and 69% if there is 4 to 5 points. Now, this should not guide the treatment, because we have seen that many patients who are having a poor score, almost 30% of them may improve by 2 years. So the delayed improvement may be there till 2 years. So it should not guide the treatment of these patients. Regarding pregnancy, there is no study regarding the pregnancy and NMDR encephalitis. There have been rare case reports in which fetal death has been noted, but it has not been documented. However, they are recommending that close prenatal monitoring and measurement of antibody, if there is history of NMDR encephalitis, even remote, should be considered before the patient is getting pregnant. So you have to be careful and have a proper pre-pregnancy counseling, and antibody titers may be done in such cases. However, more studies are required regarding this. Now, coming to a brief treatment approach, as I already told in my case, first treatment is steroids or IVIG or Plex, and 50% of this patient respond to this treatment. Second line treatment is rituximab or cyclophosphamide. And when should we take the decision of whether to start this treatment? It is different, but usually what I found in literature was it's around 2 weeks, 2 to 4 weeks. So in 2 weeks to 4 weeks time, you can decide whether you are going to the second line treatment. Some studies say that you should hit the patient hard initially itself, and then start on rituximab immediately if it's a severe disorder. So that may also be, that approach is also there. 40% respond to the second line treatment. That is 90% overall there is response. Third line treatment, other drugs like bortezomib, tocilizumab, intrathecal methotrexate, and alemtuzumab. So these 4 agents have been studied, and there have been few papers on tocilizumab which has shown that there may be good improvement in patient who is resistant to rituximab. may be given this medication. How long should you give the immunosuppressant? Again, it varies almost 1 year minimum, and some papers say it's up to 2 years also, depending on the severity of the illness. So 1 to 2 years. Regarding the antibody titer, whether you can use to guide regarding the treatment, it may not help in guiding the treatment. You have to follow with the clinical improvement of the patient. So that will be better. Now coming to one important aspect, herpes encephalitis triggering NMDR encephalitis. So this is a very important thing. There are two important triggers of NMDR encephalitis. One is the tumors, which I already told, ovarian teratomas, which contain the nerve tissue or the tumor cells, and which causes autoimmunity and give rise to the encephalitis. Second is herpes. Herpes involves the limbic area, and the limbic area is very rich in NMDR receptors. So that causes release of the receptors and antibody formation and the encephalitis. So one thing is that almost 20 to 25% of HSV encephalitis may develop this syndrome. So it is quite common. So we have to be on watch out whenever we have herpes encephalitis. Now, how do we know that they are developing an NMDR encephalitis? So if these patients develop choreoathetosis or worsening of the psychiatric and behavioral alterations, then we can suspect it is a sort of NMDR encephalitis. And in children, usually they will have movement disorder, while in adults you will have psychiatric and behavioral symptoms. This usually occurs from 2 weeks to 3 months. There are case reports in which it has occurred after 9 months also, but usually it occurs within 3 months, and it responds to immunotherapy. Sometimes GABA A receptor and dopamine receptor encephalitis has also been seen after herpetic infection. And not only herpes, various other infections also can trigger NMDR encephalitis. So this I have already told. So how do we differentiate viral encephalitis versus non-viral NMDR encephalitis? Viral encephalitis, there will be worsening of the focal neurological deficit, seizures, HSV PCR will be positive. MRI will be an important clue. You will see new necrotic lesions in the MRI, which will not be there in the NMDR encephalitis, and the HSV PCR should be negative and NMDR antibody should be positive. And usually they will have choreoathetosis, balismus and movement disorder, which will be the presenting manifestation. So you should have a high index of suspicion, and then do the MRI scan, repeat the CSF, do the HSV PCR again and NMDR antibodies, and see whether it's a NMDR encephalitis or relapse of NMDR encephalitis, or it's a relapse of herpes, or it's a new onset NMDR encephalitis which the herpes has triggered. So I think I will go to just a brief 2-3 slides. This is one study which we had done when I was in Amrita Institute, and this is in the pediatric neurology department under Dr. Professor Vinayan, and by the time I left the institute, there we had 6 cases. Now they are having more than, I guess, 50-60 cases they are having in the series. So there were 6 patients which I had seen during my posting. And here you can see that these are all pediatric patients. The mean age was 11.5 years. And all of them were females. And the predominant manifestation was behavioral changes, dyskinesias and seizures. So these were all seen in all these patients. Autonomic involvement was not seen. 2 of the patients had recurrence of the attacks. And you can see the baseline GCS. GCS was 12 or less than 12 in most of them. One had a normal GCS. Baseline workup, that is autoimmune panel, ANA and all those things were normal. CSF in 2 patients were normal. In 4 of them there was lymphocytic pleocytosis. One had oligoconal band positivity. MRI was done in all these patients. One had abnormal hippocampal and temporal lobe involvement, while others the MRI were normal. So MRI was normal in most of the cases. And one patient had a mature cystic teratoma in the MRI. Rest of them were normal. Some had polycystic ovaries which were not related. EEG was normal in 2 and 4 of them showed some abnormal slowing. However, extreme delta brushes were not seen in most of them. CT chest was also done, which was normal. Antithyroid antibodies, everything was normal. CSF and serum NMDR were positive in all of them. And all of them were treated with IVIG and steroids, and 4 of them responded. 3 had recurrences. One had 3 attacks of recurrences, which has to be treated with rituximab and then followed up with rituximab. Every 4 to 6 months we had given rituximab, and 2 patients had single recurrences, which were again treated by rituximab and was followed up with azathioprine continuation. And all of these patients were followed up for almost 7 months to 2 years and 2 months. And most of them had a good outcome, except for this patient with 3 recurrences who had a very poor Glasgow outcome scale. So mostly there is good outcome, and CSF maybe CSF is abnormal in most of the cases in our series. MRI was normal in most of them. One of them had a ovarian cystic teratoma. So I think this is my last slide. I'll conclude with this. So whenever you suspect autoimmune encephalitis, you have seen the criteria: subacute memory loss, psychiatric symptoms, movement disorders, and all those things. And then you evaluate the patient. What are the key investigations which you have to do? You have to do the serum CSF, and then you send for the antibody panel, the surface antigens, and depending on the age of the patient, if you are suspecting paraneoplastic, then you have to send the whole paraneoplastic panel also. You have to rule out, exclude herpes encephalitis and other infective encephalitis. So you have to do the CSF viral PCR panels also. MRI and EEG are the ancillary tests which may be useful. EEG, you look for slowing extreme delta brushes. MRI, you find whether you are seeing any specific pattern. And depending on the antibody which is positive, whether it's an onconeural antibody which is positive, then you have to go for the paraneoplastic workup, oncology opinion, and treatment of the tumor. If it is a surface antibody, then you have to see what type of encephalitis it is. Steroid with IVIG, first line, or plasmapheresis, and wait for almost 50% will respond. Wait for 2 weeks. If no response, go to rituximab or cyclophosphamide. Wait for 4 weeks. If no response, then you can go for third line agents like tocilizumab or intrathecal methotrexate. I have no experience regarding the third line treatment. And after that, you have to follow these patients up, do a full tumor workup. You have to do the CT scan or PET scanning if available. And if you are suspecting, if it's an NMDR encephalitis, you have to follow up these patients for 4 years, every 6 monthly transvaginal ultrasound to rule out a ovarian teratomas. And immunosuppression has to be continued for 1 year to 2 years, depending upon the severity of the illness. So that's all from my end. Thank you for the patient listening.
Thank you, Doctor, for sharing us your experience. And now I would request Dr. Swayam Prakash to please continue with the session by sharing the screen. Over to you, sir. Thank you.
Very good evening to everybody who are watching here. And I'm very thankful to Dr. Praveen, who has actually created this platform and brought me in to share my experiences. Am I visible? Hello? You can see me, yeah. So I think at the outset, let me ask you, do we have time? I can go with my presentation, or do I need to cut short? I shall try to cut short also. Okay. So today's topic is autoimmune encephalitis, and I think Dr. Praveen has done a marvelous job by dealing autoimmune encephalitis in greater details. So many of the slides I shall be skipping in the interest of time and just to avoid repetition. So basically, my scheme of presentation will be setting up the perspective. I shall be giving a brief overview of autoimmune neurology, because see, autoimmune neurology is a whole set of a stream in itself now, which undercuts all the subspecialties of neurology, be it cognitive neurology or the movement disorder or the epilepsy. And at the same time, it overlaps with the other stream of medicine like rheumatology and oncology, and it provides a wonderful interfaces to interact with the other stream people. And what's really important about autoimmune neurology, it actually gives neurologists some tool. Because up till now, it's believed that neurology is a science which is basically of diagnosing, discussing, and dispensing. And I think autoimmune neurology has provided us a tool to stand different as compared to the previous beliefs and myths. So after setting up the perspective, I'll be discussing a few of the important cases. I have chosen 4 cases. Why I've chosen this? Because few of them are real eye-openers. and few of them actually, intrigued me to a sickening extent, and even till date, I've not found many answers. So I shall be discussing and leaving up to your wisdom to think about it and come up with more answers and details. So autoimmune encephalitis. Encephalitis, we all know, is inflammation of the brain parenchyma. And autoimmune means your body's own cells start attacking your own system. So if the inflammation of brain occurs because of body's immune system mistakenly attacking the healthy brain cells, this is what, in a nutshell, in a very simplistic way, we call autoimmune encephalitis. And autoimmune encephalitis could be associated with antibodies, which could be, as Praveen told, could be with antibodies targeted to intracellular antigens, or it could be cell surface antigen. And depending on which type, the prognosis and management and the prognosis depends. Autoimmune encephalitis can result in a mix of neurologic and psychiatric manifestation we have just seen. And one thing is very important. This is a clinical teaching, that it's not the clinical characteristic, but the speed of the onset, which is more important. So onset is usually subacute, and at times it may be acute also. So onset is very, very important in autoimmune encephalitis, or rather it gives you a clue whether this is autoimmune or not. And courses may be fluctuant. And as we all know, it could be associated with cancer, and it could as well not be. Before we go on to discuss into the details about the autoimmune encephalitis, I shall be discussing a few things about CNS having immune privilege status. Why CNS is supposed to have immune privilege? Because of a few virtues it possesses. Like there is absence of lymphatic drainage, which actually limits the immunological circulation. Then we have a very robust barrier, which limits the passage of immune cells and factors, which is called blood-brain barrier. Low level of expression of major histocompatibility complex, MSC complex, particularly MSC2 in the resident cells of CNS. Low levels of potent antigen-presenting cells, like dendritic cells or Langerhans cells, and presence of immunosuppressive factors like TGF-beta and CD200. So these are a few features which actually impart CNS the privileged status. Now, very often it occurs to us why there occurs autoimmune disease. So to be precise, we don't have exact answer, but it has been postulated that culmination of interaction between genetic predisposition, environmental factors, and failure of self-tolerance maintenance mechanism leads to probably human autoimmune diseases. Now, as Dr. Praveen has elaborated various triggers and environmental factors, two words special mention, that is tumor and infection. So an infection, herpes simplex viral encephalitis and NMDR encephalitis association is very well known. But at the same time, we must know that any infection, be it CMV or EBV or varicella zoster, all are well recognized infective agents leading to immunogenesis. This is in a nutshell the immunopathogenic mechanism as how it occurs. I'm not going to go into the details of it. Sorry. Now, why are specific regions of the nervous system targeted? What are the factors that define which antigen expressing regions are attacked and which are spared? Again, we don't have a precise answer, but probably it could be because of the variability in the environmental microenvironment of the inflammatory microenvironment, or in the ability of cells to regulate inflammation, and in the target antigen expression in the form of isoforms, epitope conformation, and availability. So a complex interplay between these factors can make certain areas of the brain more susceptible and other areas a bit resistant for such immunological injuries. A limbic system is very important structure so far as autoimmune encephalitis is concerned. And we all know that limbic system is a seat of cognition, affect, and autonomic regulation. It actually is comprised of amygdala, hippocampus, fornix, corpus mammillae, hypothalamus, and cingulate gyrus. So these are the main areas which actually constitute limbic system. And in autoimmune encephalitis, this is the prime target. This is the anatomical substrate, and which results in a mix of psychiatric and neurologic manifestations. Now, autoimmune encephalitis in a very simplistic way can be defined, classified as association, those set of encephalitis which have neoplastic association and those which have antibodies association. So neoplastic association can also be further subdivided into paraneoplastic and non-paraneoplastic, and those associated with antibodies could be because of antibodies against cell membrane antigens or antibodies against intracellular antigen or synaptic antigens. This is a busy slide. It shows overview of the neural antibodies and their associated neoplasms according to the nervous system level involved and neurologic manifestations. Just I want to show you here one thing. Look at the structures which are susceptible for the involvement by autoimmune encephalitis. It can involve cerebral cortex, can involve diencephalon, basal ganglia, cerebellum, brainstem, spinal cord. Even beyond that, I mean, even the nerve roots, nerves, neuromuscular junction, muscles, all can be involved. But for today's discussion, we have confined to the CNS part only, and so the entire neuraxis can be involved. And depending upon the involvement, we could have various presentation, syndromic presentation, like it could result in encephalitis, it could result in hypothalamic dysfunction, in cerebellar ataxia degeneration, or brainstem encephalitis, or spinal cord syndrome. So depending upon which level of neuraxis is involved, it can lead to various varieties of syndromes. This is a list of antibodies, recognized antibodies, should I rephrase, related to autoimmune encephalitis. So it has NMDR is the most common one, and followed by LGI1. And then we have plethora of antibodies. And every other year, we get a couple of more. So this is how it's expanding. So this list is not exhaustive. Just this is the recognized antibodies to date. And this chart shows the syndromes, the various characteristics, the MRI features, and their association with various tumors. Clinical presentation, to be very simplistic, it could be subacute or acute onset with fluctuating course. There could be febrile prodrome, and there could be a mix of psychiatric and neurologic manifestations. Psychiatric manifestations could be in the form of behavioral changes, agitation, psychosis, and neurological manifestations like cognitive impairment, seizure, movement abnormalities, altered sensorium. I mean, all these in various combinations could be possibilities. Now, certain antibodies have characteristic clinical phenotype, like Dr. Praveen has already enumerated. Orolingual dyskinesia are very common in NMDR, and facial brachial dystonic seizures very common in LGI1 antibody. But it's not exclusive to those set of syndromes only. There are case reports of orolingual dyskinesia in LGI1 and facial brachial dystonic seizure in NMDR. So all are possible, but then they signify more one set of conditions. And then there are certain comorbidities like hyponatremia, which is more common in LGI1 antibody, and diarrhea, which is more common in anti-DPPX antibodies. And there are a few more comorbidities like sleep apnea, which is more common in Eglon5. So our knowledge is expanding regarding the characteristic phenotype of particular antibody. We need to do a lot of other investigations to rule out the mimickers. But if you ask me 3 investigations, these are MRI brain, EEG, and antibody test in CSF and serum. These are 3 important investigations on which the diagnosis of autoimmune encephalitis actually rests. This was a very important paper, position paper by Gross et al., published in April 2016 in Lancet Neurology. Why it's important? Because it actually tried to address the problems faced by the clinicians. Like, we have a patient and in whom we are suspecting this to be because of the autoimmune origin. Then what to do next? When to start immunotherapy? Can we start immunotherapy even without establishing the final diagnosis? So these are a few of the dilemmas which actually this position paper tried to examine and answer. And what it came up with, it states very clearly that initiation of treatment should not be delayed in the pretext of waiting for the antibody report. So whenever we are suspecting a case of autoimmune encephalitis, we should straightway go ahead and deal with the immunomodulatory therapy. So this paper also actually gave diagnostic criteria for the possible autoimmune encephalitis, for the definite autoimmune encephalitis, and for the autoantibody negative possible autoimmune encephalitis. So autoimmune possible and definite was dealt by Dr. Praveen, so I won't go into the details. I'll stick to the autoantibody negative possible autoimmune encephalitis because this is very interesting. Many a times we are suspecting the case to be autoimmune encephalitis. We are sending the samples of CSF and serum, and that comes negative. But we have all reasons to believe that it's autoimmune encephalitis, and then we should not delay the treatment in this set of patients also. So this again says the same thing. If we have progression, rapid progression, that should be less than 3 months duration, and with the involvement of working memory, psychiatric symptoms, and mental status, and this MRI finding is suggestive of encephalitis, and CSF shows pleocytosis, or some specific oligoclonal bands are found, then we have every reason to suspect this case to be autoimmune encephalitis if we can reasonably exclude alternative causes and we can exclude well-defined syndromes of autoimmune encephalitis like Adam and Bickerstaff. So this topic of autoimmune antibody negative encephalitis is very close to my heart because most of the times we can't wait. We are working in a setup where the diagnostic tests are not available right up front. We need to send the sample, wait for 6-7 days. So we can't afford to do that because if we delay the treatment, neuronal injury is going to take place and the prognosis is going to be adversely affected. So we should be cognizant of the fact that autoimmune antibody negative variety of encephalitis are also, common. And if we have clinical suspicion, we should go ahead and treat the patient as the autoantibody positive patients. Now, what are the alternative causes? As we were talking about the exclusion of alternative causes, in all the criteria, there is a bottom line which states that exclusion of alternative causes. So the alternative causes could be anything. It could be CNS infection, it could be septic encephalopathy, metabolic encephalopathy, drug toxicity, cerebrovascular diseases, some neoplastic disorders, degenerative disorder like Creutzfeldt-Jakob, rheumatological disorder, mitochondria. The whole host of condition could be there, and we should try and rule out the possible alternative causes. Management, to be very simple, management is immune modulation. That's the mainstay of therapy. And then we have first line, second line, and chronic maintenance therapy. So a disease which is not that common, we cannot have a guideline for that. Whatever we have is consensus, and guidelines are evolving and changing time to time. It's not a fixed guideline. So at this point of time, the immunomodulatory agents which are available and the dosing regimens are given in this table. And we see the first line immunotherapy is methylprednisolone, IVIG, and plasma exchange. We basically depend on these for the first line. And for the second line, we have rituximab, cyclophosphamide. But one thing important about rituximab is it's gaining very fast favor by neurologists and oncologists, and very often than not, it's used as first line agents also. So this is the status of rituximab at this point of time. So now I'm coming to with this preamble, I'm coming to my cases. As I'll try to be brief and try to show you the important videos and what are the observations to make. So the first case was 15-year-old girl who presented with 2 weeks history of altered sleep, behavioral abnormalities, 3 episodes of generalized tonic-clonic seizure spread over 4 days, followed by altered sensorium, and there were no history of fever, headache, or vomiting. Examination revealed GCS E1 M5 V1. Pupils were bilaterally normal size and reaction, planters bilaterally equivocal, no meningeal sign, and her GCS further worsened, for which she had to be intubated and put on mechanical ventilation. MRI brain showed signal changes in bilateral cingulate gyri, posterior occipitotemporal lobes, and right parahippocampal gyrus. The screening of MRI spine was within normal limits. CSF study showed cells pleocytosis in the form that cells were 20 and predominantly lymphocytes, sugar 62 milligram per deciliter, protein 52 milligram per deciliter. So there was some cells, some mild increase in protein, and all of the tests were negative. We ran a bacterial meningitis PCR also, which also came negative. So based on this, we made a tentative diagnosis of subacute encephalitis syndrome, etiology being autoimmune or paraneoplastic or viral. We were not sure till that point of time. And we initiated treatment with proper antibiotic, antiviral, antipyretic, antiepileptics, and supportive care. And in view of her prolonged requirement for mechanical ventilation, tracheostomy was done after giving due counseling to patient party. During her stay in ICU, she developed orolingual dyskinesia and multiple coriform movements. So now you just see the videos. So can you see the videos? Videos are visible?
Yeah, it's visible.
Okay. So just have a look at this. Look at the oral movement, this puckering movement. So this is orolingual dyskinesia. So in the interest of time, I will switch over to the next video, wherein you see more florid orolingual dyskinesia here. Orolingual dyskinesia got even worse on next couple of days. And in the next video, you see the coriform movement here. So, while the orolingual dyskinesia is also going on here, but you see the multiple coriform movements here. So, as discussed, orolingual dyskinesia and coriform movements are a bit more common with NMDR. It's not that it's the telltale sign or it's the diagnostic or sine qua non of NMDR, but it's definitely pretty common in NMDR compared to other set of autoimmune encephalitis. So, and she also developed marked autonomic dysfunction in the form of fluctuating heart rate and blood pressure, episodes of hyper and hypoventilation, and perioral diaphoresis. So, possibility of autoimmune encephalitis was even more clearer, and that time panels were not available. So, we sent NMDR and anti-VGKC. A patient was started on weight calculated dose of IVIG, and she showed fair improvement in a few days time. Roughly after 6 to 7 days of IVIG therapy, she started showing improvement. In the meantime, reports came in, and it was positive from both CSF and serum. So the diagnosis of NMDR antibody encephalitis was established, and anti-VGKC was negative. And other paraneoplastic panels were asked, that came negative, except for NTU, which came borderline. This again gave us inkling that probably she is having ovarian teratoma. And that came positive in, I shall show you the CT scan of pelvis. So patient had remarkable improvement by third week of her admission, and gradually her tracheostomy tube was removed. And just have a look at the various cognitive tasks which she was asked to perform. Look at the first, attempt. She failed severely. She could not make a clock. And then gradually she improved, and she started doing all these beautiful sketches of flower, cube. She made a wonderful clock, and she also attempted complex multiplication. So she could perform very well cognitively in the subsequent days. And this is the Thanksgiving card by her to the treating team. So she was discharged in fully conscious, alert, and oriented state. And I shall show you the video. What's your name? Just on the day of discharge, she was fully conscious, alert, raise your right arm, and following commands. She was understanding. Left arm. So, and she was asked to perform some complex movements, which were also very easily done by her. Blow. Yes, good. Show me how to clap. So she was doing well, and she was discharged. Her CT pelvis showed teratoma here, ovarian teratoma, and for which she was right ovarian teratoma, for which she was advised gynecological opinion and removal of teratoma. She then went for a second opinion to Apollo Chennai after discharge from our side, and then it was done there. Again, the histopathologic specimen, the report read mature cystic teratoma. So she came after the removal of teratoma, and here was a young, healthy, bubbling girl. So this is how, the timely intervention makes difference in the life of the patient. This is one publication we made while I was doing DM. I was in the final year, and it was anti-NMDA receptor encephalitis, which actually was referred to us by a psychiatrist. And therefore, I want to emphasize here that initially patient can have pure psychiatric feature, like Praveen said in his presentation. And this patient also came to us with pure psychiatric presentation, and therefore I purposefully titled this as a neurologic disease in psychiatric disguise. So this is how it actually presents. So NMDR has been dealt in length and breadth by Praveen. I'm not going to go into details. I shall just briefly tell you a few of the important things. See, NMDR is not a very old disease. It was discovered first in 2007 by Delmao et al. Reported. And it's a multi-stage illness. And it presents with a bewildering mix of behavioral and psychiatric movement, speech, autonomic, and brain stem dysfunction. Children and adolescents are mainly affected. However, no age is barred. Occur when body's own immune system attacks NMDA receptor in the brain. And how it does was very well dealt by the previous speaker. And it's often mistaken for viral infection. A recovery for these patients depend on early recognition of the complex sign and a multidisciplinary approach and comprehensive care. I shall just briefly go through these slides. See, it presents in a multi-stagic illness kind of. Earlier, the first is we see patient in prodrome, which is very, very non-specific. Patient can have fever, patient can have malaise, and all sort of flu-like symptoms can be present. And what I want to emphasize here, during the clinical worsening phase, the initial phase is, mostly psychiatric manifestations like agitation, psychosis, hallucinations, etc. And later on, it becomes more neurologic with the manifestations like seizure, abnormal movements, coma, etc. And what we do by starting early therapy, we can reverse the process fast. So this is, in a nutshell, I wanted to show through this cartoon. Now, as is well known that it causes affection of the limbic system. So here we see a slight hyperintensity left more than right of the medial temporal lobe, and this is not usually enhanced on contrast. So this is typical presentation, imaging presentation of NMDAR. One thing we should be cognizant of the fact, it's not only the limbic system which is affected by NMDR or other, autoimmune encephalitis. Even extra limbic systems can be affected. So this was one case which I saw. It actually affected, the caudate. So bilateral caudate, left more than right, and also, pulvinar, thalamus is affected. So it can affect extra limbic system also. And we should not just dismiss it that it's not NMDR because it's not, affecting limbic system. And as Praveen told, that in roughly 40 to 50% of patients, we cannot find any abnormality. It can come all normal. Even then, we have to think in the light of the clinical background. And EEG, usually it shows a non-specific slow and disorganized activity, sometimes with electrographic seizure also. But what is important is at times it could be diagnostic also if we can find extreme delta burst, which is supposed to be a unique EEG pattern in adult with NMDA or encephalitis. So this looks like this. This is the presentation. It's a delta wave and overridden by fast beta activity. And this is predominantly seen in the frontal, leads, frontal channels. So these are basically the EDBs. And we all know these are the line of treatment. We have first line IV methylprednisolone, IVIG, and plasma exchange, and second line rituximab with cyclophosphamide. And tumor removal enhances the effect and the speed of treatment, and therefore the chronic tumor surveillance has been considered as a long-term management strategy. Now I shall go on to the case 2. My case 2 was 45-year-old female without any past personal or family history, and who presented in emergency room with complaints of recurrent seizure 6 to 7 times. And semiology of seizure was suggestive of generalized tonic-clonic without regaining consciousness for last 3 to 4 hours. And there was history of new onset seizure for say 20 days, last 20 days, in which she had 6 episodes. And on examination, patient was in altered sensorium. GCS was E2, M4, V2. Pupils were bilaterally 2 millimeters reacting to light, moving all 4 limbs to painful stimuli, hyporeflexive deep tendon jerks. Plantar were bilateral equivocal, no meningeal sign. CBG was 141 and ABG is showing hypoxia. The patient was initiated on the standard treatment protocol for convulsive status epilepticus, and seizure was controlled. Seizure was controlled on IV valproate 500 milligram IV twice daily, and levetiracetam 1 gram IV twice daily, with injection lorazepam 4 milligram IV SOS. And her sensorium also improved, but she appeared confused, forgetful, more sleepy during daytime, with abnormal behavior and tendency to run away from her bed or chair. Sensorium fluctuated on day-to-day basis and also during different times of the day. Patient occasionally showed dissociate clinical response and autonomic fluctuations in the form of fluctuating heart rate, blood pressure, and respiratory rate. Detailed cognitive and behavioral examinations were planned, however, it could not be done. Now, this is the video on day 3, when she appeared very much confused. She could just tell her name after repeated asking, but she was not alert and disoriented to time, place, and person. She was not even bothered who is asking what. With this, we got the MRI also, which was non-contributory. We just showed some focal, cortical, subcortical hyperintensities on flare in bilateral frontal region. So these were non-contributory actually. And EEG showed brief paroxysm of slow waves with evidence of post-sedation effect. CSF showed cells were just 4, but protein was 75, and all of the tests were negative. NT-TPO was high here. And we sent a sample for autoimmune paraneoplastic panels, and we started the treatment with IVIG. And later, GABA B1 B2 receptor antibody came strongly positive. And even after the completion of IVIG, patient's cognition and behavior did not improve much. And here, I would like to show you here this anti-GABA receptor antibodies were strongly positive here. And other autoimmune paraneoplastic panels were negative. Her PET MRI brain was done, showing features consistent with autoimmune limbic encephalitis. However, whole body PET did not show any abnormal uptake, and patient went LAMA. Patient did not want to continue with the treatment. When I suggested that patient was not improving, let us go ahead with plasma exchange or rituximab. So they said, no, I'll take second opinion, and then they went LAMA. But after 3 weeks, patient again came. When she came after 3 weeks, that time she was conscious, alert, following commands on repeated request, but disoriented to time, place, and person, and talking irrelevantly. There were some hallucinations also confirmed by the patient's son. Our patient was moving all 4 limbs equally, hyporeflexive deep tendon jerk and bilaterally flexor plantar with no meningeal sign. So after again counseling, patient was initiated on plasma exchange, and after third cycle, she showed cognitive and behavioral improvement, which further improved. Now this is the video after plasmapheresis. This time, patient was more conscious, following commands, but there was a bit of perseveration seen here. Even after asking to close your mouth, she'll keep protruding her tongue. But definitely she was able to, she was definitely better than before. So a few words about GABA B receptor antibody encephalitis. This is a rare condition presenting typically with the features of limbic encephalitis in the form of memory loss, confusion, and prominent seizures. GABA B receptor encephalitis can present with the status epilepticus without any provoking factor. This is one thing which I want really to emphasize here, that GABA B receptor encephalitis can present straight with the status epilepticus. So especially in the middle-aged patient, when association with cognitive and behavioral features are there, these could serve as pointers towards the possible diagnosis of GABA B receptor encephalitis. Now about the case 3. Case 3 is important because there was disconnect between the antibody which we got on the test report and the syndrome with which he presented. So this was a 56-year-old male, known case of hypertension, type 2 diabetes mellitus, and hypothyroidism, presented with complaints of abnormal behavior in the form of easy irritability, jitteriness, poor interaction with people around, forgetfulness for the recent events, disturbed sleep, and off and on low-grade fever for last 20 days. On admission, he was just confused, otherwise he was pupils were bilaterally 3 millimeters reacting to light, and all other things were, not contributive. All other things were roughly normal. But later on the day of admission, patient had an episode of generalized tonic-clonic seizure followed by altered sensorium. And this is the MRI. This is very important for we all neurologists to look into the MRI ourselves, and we should try to look at the target regions. With the background of the history which we got in this patient, these are our area of interest, limbic area, especially the mesial temporal areas. So here we see some signal changes here, left side more than right. Here again we see the similar changes, left more than right. Actually, why I want to emphasize on this point, because earlier these imagings were reported normal. Earlier, these reportings were reported normal, and when I asked my radiologist neurologist colleague again to look into it. Then he said, and he nodded, yes, there are some signal changes. So CSF study showed pleocytosis. Cells were high, 210 with 65% lymphocytes. Protein was high, 179 milligram per deciliter. And other tests were roughly normal. EEG revealed only drowsy record showing brief paroxysm of generalized symmetrical and bisynchronous biphasic and triphasic wave morphology. And based on the above observations, possibility of subacute encephalitis syndrome was thought of, and possible etiologies being infective or autoimmune or paraneoplastic, we didn't know by that point of time. So we sent CSF pan-neurotropic viral panel, CSF TB-PCR, and autoimmune paraneoplastic panels. But patient's condition further deteriorated, and he had to be put on mechanical ventilator. And in the interest of patient, without waiting for the antibody reports, we started plasmapheresis. And by the completion of the second cycle of plasmapheresis, he showed a very good improvement. And we gave 4 cycles of plasmapheresis in that patient. And gradually he was weaned off ventilator. Later on, his reports came positive for anti-UO antibody. So the diagnosis of anti-UO antibody limbic encephalitis, I mean, this was something which didn't occur to us. Why? Because anti-UO antibody usually doesn't cause, or rather, that time when I searched for the literature, I didn't find any case reported as anti-UO antibody encephalitis, limbic encephalitis. So I consulted my seniors, my teachers, and he said that it could be a stray finding. So better level it as anti-UO positive limbic encephalitis-like presentation. So I did that and treated the patient. This was her anti-UO positive report, and other parameters, the panels were negative. So, and he was evaluated for occult malignancy by CT chest, CT abdomen, USG, salivary gland. His vasculitis markers were negative, and his whole body CT PET was planned, but patient party declined actually. Patient gradually improved. Patient was weaned off ventilator, tracheostomy tube was removed, and patient was mobilized. At the time of discharge, patient was conscious, alert, following commands. Speech was hypophonic, possibly due to prolonged tracheostomy. He can sit unsupported and stand and walk with 1 person support, and was continent of stool and urine. So there are a few points which I want to bring to the fore for for considering this, where do we stand in this case, whether that was a stray finding, whether NTO can present like limbic encephalitis. These are a few things still unanswered, and I want this house also to get more proactive into such kind of meticulous reporting. So actually limbic encephalitis by NTO antibody has not been reported, or by that time was not reported. And limbic encephalitis is mainly caused by the antibodies of MPA receptor, GABA-B, NMDA, LGI1, mGlu-R5, or even by the anti-WHO, MAR2, CV2, CRMP5, etc. And small cell lung carcinoma and testicular germ cell tumors are mostly associated with the limbic encephalitis. And the NTO was mostly associated with the paraneoplastic cerebellar degeneration, which is characterized by rapid development of severe pancerebellar dysfunction. And the usual clinical features are truncal and appendicular ataxia, dysarthria, and downbeat nystagmus, which was not present in that case. So, and one thing more, the anti-UO PCD has not good prognosis. The result with the immunotherapy is not good, but in our case, the patient responded well. So our case was distinct due to the fact that association of anti-UO antibodies with limbic encephalitis-like presentation is very rare. That too in male, because we all know anti-UO is mainly expressed by ovarian tumors. However, salivary gland tumor, small cell lung carcinoma can also be associated with NTO. And response to immunotherapy was very good or reasonably good in our patient, unlike the usual PCD cases. So this case was distinct, but we are still not sure whether it was a stray finding or NTO actually manifested in a different form. So this is something we would learn in time to come. So the bottom line, which I learned and which I want to share with you guys, that atypical presentation of a particular antibody type are though rare but are on record in literature, which can further be enriched by such meticulous clinical research and reporting. So this case re-emphasizes the fact that paraneoplastic antibodies can have atypical clinical presentation, and a high index of suspicion should be maintained to pick them up early and treat them accordingly. Now coming to my last case, this is again very interesting case because it's more intriguing than interesting. So how is it, which I'll see as the discussion progresses. This was a 58-year-old male who presented with complaints of acute onset imbalance and clumsiness associated with mild slurring of speech, followed by confusion and jitteriness for 8 days. No history of recent febrile illness, seizure, loss of consciousness. One thing was very clear in this case, that he came with a level diagnosis of paraneoplastic encephalitis. Earlier, roughly 8 to 9 months back, he was admitted at some other center where he was diagnosed to be NTO positive encephalitis, NTO positive encephalopathy, and patient that time also improved quite well with immune modulation therapy. So this time when he came, I didn't have diagnostic dilemma. I was knowing that probably it's a relapse. So I examined the patient. On examination, the only thing remarkable was gait ataxia. Otherwise, everything was okay, kind of. The patient was conscious, alert, only disoriented to time-pleasant person, and ataxia was there. Otherwise, other examinations were roughly within normal limits. So after evaluation of a possibility of relapse of paraneoplastic autoimmune encephalitis, I asked for the MRI brain, which showed, which was non-contributory in this case. CSF showed piocytosis, cells were 17, protein was 91, and treatment was initiated after sending autoimmune paraneoplastic panel straight away, and with the IV methylprednisolone first for 3 days, followed by IVIG. And to this, patient responded very, very well. Patient improved by day 4 of the patient. Remarkably, he was fully conscious, alert, oriented, performing all cognitive tasks. His gait also improved remarkably. So, but reports came, actually this time it came positive for another antibody, that was anti-empiphysin antibody, and NTO came negative. Just have a look at this. So anti-empiphysin was positive, and NTO, which was earlier positive, came negative this time. I shall show you the earlier report also. This is the earlier report, which was done in September 2019, when the NTO came positive. And that time, anti-empiphysin was borderline. So I was at a sea, and I could not explain it well even to the patient party, because when he asked how could it happen, I had to give my theories. And I said maybe different lab, different report, or one of the report was wrong, or whether this is false positive, or whether this is clinically irrelevant. But one thing which actually appealed to me, so could it be the changing expression of the occult tumor? So could it be possible that tumor which was earlier expressing anti-U antibody and was given immunomodulation, so anti-U was not there, it became negative for that, and now it started secreting or expressing another antibody. So these are the few intriguing facts which I could learn from this case, and still learning, because answer is yet not clear. Now a brief, crisp few words about anti-empiphysin antibody. So anti-empiphysin antibody may be associated with stiff person syndrome or progressive encephalomyelitis and sensory neuronopathy. Small cell lung carcinoma and breast carcinomas are the common associations for anti-empiphysin antibody. And while I was searching literature, there was a point which states that it may be associated with other antibodies. So whether it was association with other antibodies like NTO, we are not sure. But one thing very interesting which I could learn, that anti-empiphysin 1 antibodies may be useful in predicting paraneoplastic origin of neurological disorder in a given patient without known cancer. So if a patient is having anti-empiphysin 1 antibody positive, and even if we have by detailed and exhaustive measures of investigation, we could not find any tumor, even then we should consider this as paraneoplastic origin. So this is one of the marker of it. So to summarize, autoimmune encephalitis is fast emerging as major cause of non-infectious encephalitis. Subacute onset of a mix of psychiatric and neurologic features are the important initial clues. Autoimmune encephalitis is fairly responsive to immunomodulation therapy, though it depends on the type of antibodies association. Antibody-negative anti-autoimmune encephalitis is a new emerging concept like seronegative polyarthritis. I think most of us will agree to it. Presumptive diagnosis and quick initiation of treatment lie to the core of effective management. An occult tumor must be looked for, and chronic tumor surveillance should be a part of long-term management. Is a very, very important point. So now I conclude, and thanks for your patient hearing. I wish you all very safe stay during this COVID pandemic. Thank you very much.
Thank you, Doctor, for briefing and sharing your experience with us. Doctors, I would like to share with you that during the registration process, we had requested all the doctors if they would like to share any questions with us, which should be asked with you. So I would like to share the screen where the questions are being presented. So,
yeah. Sure.
Just a second, sir. I'll be doing it. Sir, I'm sorry I couldn't share, but I'll just directly ask the questions.
Okay.
Is there
Sorry?
Hello. I think the voice is not clear.
Hello.
Can you ask the question again?
Yes, sir. I will repeat the question. Is there any method to clinically diagnose autoimmune encephalopathy without the special test, as during these COVID times, it is not available everywhere?
Yeah, that is what has been explained. So it depends upon we have the clinical criteria in which you are having the subacute onset of memory issues, cognitive problem, the neuropsychiatric symptoms, and all those things, the clinical feature. And then after that, if you do the CSF, you are getting high protein or a positive lymphocytic pleocytosis or a oligoconal band positivity, which shows that there is intrathecal protein synthesis and EEG abnormality, or with or without a positive MRI. So putting all this into the criteria, definitely if you are having the clinical suspicion and the investigation supporting you, then definitely you can start the immunotherapy regardless of the antibody panel, because it may not be required if the clinical criteria is satisfied.
Thank you, sir. So the next question, which is being asked by the audience in the chat box, is what triggers autoimmune encephalitis?
Sorry?
What triggers?
Yes, sir. What triggers autoimmune encephalitis, and what would be the treatment for it?
So that we have already discussed. The most important triggers are tumors and viruses, and the malignancies and all those things. And the treatment also we have discussed during the discussion.
So the other question which is being asked is how to differentiate between autoimmune encephalitis versus ADEM.
I think there are set criteria for Praveen, would you answer?
No, I think the question is autoimmune encephalomyelitis versus ADM. Is it?
Yes, sir. And autoimmune encephalomyelitis versus ADEM.
See, ADM is a post-infective syndrome. ADM is a monophasic illness which is characterized by fever, altered sensorium, seizures, and optic neuritis and spinal cord involvement. So that is a post-infective syndrome with a history of some infection, some vaccination, which has occurred, and it's a monophasic illness. It occurs single time, and then there is spinal cord as well as brain involvement and optic nerve involvement. So it is also an autoimmune pathology due to some trigger. Now, the word autoimmune encephalomyelitis, which has been asked. So there are three types of autoimmune encephalomyelitis which can occur. One is a neuromyelitis optica spectrum disorder, NMO, and second is a MOG disorder, and third is a GFAP or glial fibrillary acid protein disorder. So all these three can present with similar pattern with optic neuritis, brain involvement, and spinal cord involvement. So if you look at these are all relapsing disorders. So there will be relapses, the spinal cord involvement will be there. And there are a lot of criteria which includes the MRI lesions, the CSF abnormality. And with all this, you can differentiate ADAM, because in ADAM, you will have CSF lymphocytic pleocytosis will be there. There will be neutrophilic pleocytosis also if it's hemorrhagic ADAM. And OCV positivity will be less, while in the cases of NMO, usually 10 to 15% will have OCV positivity, and the characteristic lesions of NMO will be in the periventricular area where the aquaporin channels are there, while ADAM, the lesions will be large demyelinating lesions, and so it's a lot of features are there, and then aquaporin antibody will be positive in NMO, while MOG antibody will be positive in the MOG disorders. Actually, ADAM and MOG may be a spectrum. So most of the cases of ADAM may be MOG antibody disorder, because these are just coming a few years back. So we are not testing for the MOG antibodies in the ADAM. So most of the ADAMs and MOG may be similar disorder, while NMO and GFAP are different sort of disorders. So using the clinical criteria, MRI picture and all, we can differentiate these disorders. And the treatment is different, because for ADAM, you need not give prolonged immunosuppression because it's a monophasic illness. While for NMO and MOG and GFAP, you have to give prolonged immunosuppression because there may be relapses, especially for NMO spectrum disorder.
Thank you, Doctor. Dr. Swayam, sir, the next question is being asked for you. What are the most advanced latest diagnoses for autoimmune encephalomyelitis?
What is most advanced latest diagnosis?
Yes.
Yeah, diagnosis tool you are asking of.
The question, I think, is not correct.
See, I shall just try to simplify it. See.
Yes.
Firstly, we need to look into the clinical criteria, because see, everything starts with the history and what do you find on examination, because that sets the background, and based on which you actually go on to the next level of diagnostic test. Now, in the diagnostic test, as I said, there are three important clinical diagnostic tools we have. One is MRI, second is CSF antibody and serum antibody, and third, at times it could be EEG also, which could be diagnostic in certain variety of autoimmune encephalitis. But then more advanced imagings are available, like CT, whole body PET or MRI, which also, like in one case which I showed you, GABA B1, B2, where MRI was negative, but when we did, that was MRI PET rather. So when we sent the patient for MRI PET, the patient came with the report, there was a clear-cut affection of the medial temporal lobe limbic areas in those set of patients. So these are the higher modalities of investigations available, which we at times can use. However, most of the diagnoses are only made by 2-3 important diagnostic. One is the clinical observation, second is the MRI or the imaging findings, and third is the CSF and serum antibody test, because antibody test is the main thing on which the entire diagnosis rests. Whether this is, even if it comes negative, then we can call it antibody negative if our index of suspicion is very, very high in that set of patients. And if the patient shows at least some amount of improvement after giving immunomodulation. Then we can, in retrospect, say that it was antibody negative. So this is how actually we do. Though the question was not very clear, but I just tried to simplify it. Probably that would help the the one who has asked it. Thank you.
Thank you so much, sir. Sir, we will take up this last question, which has been asked to Dr. Swayam, sir, again. What is the role of IVIG in primary neuropsychiatric systemic lupus erythematosus?
I think this discussion is beyond. This question is beyond the discussion of today's purview. But even then, for the lupus-related psychiatric manifestation, the first thing we give is IV methylprednisolone. That has a very good role, an important role. And once patient is not responding to that, we can go for the next level of immunomodulation, where IVIG and PlasmaGen both can be used there also. However, I'll sum up saying that this is not the beyond the scope of today's discussion. So we didn't we didn't show any slide regarding that. So in a nutshell, you can take it like that.
So neuropsychiatric lupus, I think it's a severe lupus like renal lupus. So I think the choice is steroid, IVIG, and then cyclophosphamide can be tried in refractory patients. Usually.
It's true. We can start and then escalate the way we do in rest of the immune conditions. Yes.
Thank you so much, sir.
Want to add anything, Praveen, to this?
Yeah.
Do you want to add anything to this, to the last question?
No, nothing much, because CNS lupus and renal lupus. So these are the cardiac lupus. These are the serious lupus manifestations. So usually the best drug which they use is cyclophosphamide, and plasma and IVIG to tie it up, and then cyclophosphamide they can maintain probably for 6 months. So that is what they do.
Okay. Sure. Thank you.
Sorry, sir. There is one more question to Dr. Praveen. Can we start immune therapy on clinical if no facilities? This question is being asked by Dr. Hemant from Patna.
Yeah, definitely. So that is the concept of like the clinical criteria of possible autoimmune encephalitis. So if you have the clinical picture, subacute onset of memory, cognitive movement disorder, psychiatric illness, and all those symptoms coming up, so the clinical criteria is satisfied. And after that, you look at the CSF if there is lymphocytic pleocytosis or there is OCB positivity and protein elevation. So that again signifies there is some inflammation going on. EEG is showing some diffuse slowing or some temporal lobe slowing is there, or some EEG characteristic finding like extreme delta brushes, and MRI showing abnormalities involving the cortex. And if with the CSF you have ruled out a viral encephalitis like herpes and the common viral panels, if everything is negative and you find that the protein elevation is there, clinical picture is suggestive, then definitely you have to give the immunotherapy, even if the antibody, if you are not able to send the antibody, or even if the antibody is negative, you have to treat this patient.
Here I would like to add one thing. May I?
Yeah, sure.
Yeah. So actually this question, I was talking about one position paper by Gross et al., which featured in April 2016 in Lancet Neurology, that actually addressed this problem, because many a times we see there are problems for the clinician that even if we suspect the patient to be an autoimmune encephalitis, right up front we don't have the facility at many centers of autoantibody testing. One. Second, antibody testing takes time to come, 6-7 days, more than that. And third, even antibody negative does not mean that the patient doesn't have autoimmune encephalitis. So that paper actually tried to examine and answer these set of questions, that even on the basis of clinical suspicion, we can start immune modulation therapy right up front. And because rather they said that we should start. It's not the question of may or can. We should start, because even in these set of conditions, time matters. Otherwise, immune-related injuries may occur and it can adversely affect the prognosis. So, like you said very rightly, that based on the clinical criteria, if the patient is having subacute illness, less than 3-month duration, with the affection of the sensorium, or the personality change or the limbic system affection and those CSF and MRI findings, we can go ahead and treat it, and rather treat it fast to get the optimum result. Yes.
Thank you so much, doctors. We totally appreciate and thank you so much for giving your time and making your time available for us. And the audience have really liked the session. They have even they've even asked the questions what they have been asked for you. Thank you so much, sir.
Thank you. Thanks very much. It was a pleasure.
Yes. Yes, sir. Good evening to one and all in the audience. On behalf of entire PlasmaGen Bioscience family, I cordially thank you to spend your Sunday evening with us. PlasmaGen Bioscience is proud to complete this webinar under the guidance of Dr. Praveen Kumar and Dr. Swayam Prakash. For those who joined late into the session or might have missed a few minutes, please be assured we'll be sharing you the entire link session at the earliest we'll be sharing it by the email. We do have your contact details and eagerly looking forward to connecting with you for our future sessions. Thank you once again. Good night from all of us in PlasmaGen. Thank you.
Thank you. Good night.